Bismillahirrahmanirrahim. My name is Dr. Amber Rashid, and today my topic of presentation is Epidemiological Approach to Evaluating a Screening Program under supervision of Professor Dr. Saira Afzal. In this presentation, I shall be explaining introduction, assessing the effectiveness of screening programs, role of natural history, bias, role of study designs with recent advances and MCQ session at the end. At the end of the presentation, the participants will be able to describe the methodological issues that must be considered in deriving inferences about benefits that may come to those who undergo screening tests. While evaluating a screening program for any type of health service, screening evaluation programs can be done through process or outcome measures. So assessing the effectiveness of screening programs using operational measures includes what number of people are screened, the total proportion of target, the total proportion or the target population, detected prevalence of preclinical disease, cost of the program, the cost effectiveness and cost benefit analysis is important for this part, and predictive values for the tests in population screened. When we come to the outcomes, the answer to the question is whether the patient benefits. And what outcome is there when we are considering the mortality, the morbidity, the case fatality rates, the reduction in complication, and the overall improvement in the survival rate. So to discuss the methodological issues for evaluating the screening programs, just a brief highlight of how the natural history, or what is the natural history of the disease, and what is the timeline where the screening should be applied for the proper early diagnosis, and certain types of bias is also introduced due to this screening, early detection and screening. But overall, the screening process benefits the population, and the timeline is that this picture shows how this disease starts. Before the disease starts, there are no symptoms, but when the biologically there is an onset of symptoms, the disease is present, and then there is a clinical outcome that can be in terms of morbidity or mortality. And and when we are considering the screening, then we divide the whole of this period into preclinical and clinical phase. This preclinical phase is the period where we target the screening test. And in terms of prevention, the primary prevention in mostly in this phase where the no disease is present. In preclinical phase, we apply the secondary prevention, and at this point, before the biological onset of disease, the point where we apply the screening test for early detection of the disease. Natural history of the disease with specific primary, secondary, and tertiary measures is important to treat and prevent the deaths and complications, and to treat early and to treat the disease early. And it depends on how aggressive the disease symptoms are, how aggressive the disease is progressing, and that determines how long the period of survival would be for the person. So there are several biases that are introduced in while using the screening test, and that is the measure by which we can assess the screening programs. Either it introduce the lead time bias, the length time bias, the misdiagnosis, the overdiagnosis bias, the misclassification bias. These are the most biases that are according to the study designs that are evaluated, and then the screening program is assessed. So first of all, there is a lead time bias. And lead time bias is actually the time by which the time of diagnosis is advanced, meaning that if the screening test is applied, so the time we buy for the person before the usual onset of the disease, then this leads to the lead time bias compared to the usual time of diagnosis. As you can say in picture A, this is the normal timeline, and in the preclinical phase, this is the where the disease detected by screening, and later on the first symptoms appeared. This no disease, this biologic onset of disease, and in this time we are showing the lead time, actually where the detection was done by screening and diagnosis was done, and the time between the usual time of diagnosis, the lead we get by early detection of the disease is the lead time, and it reduces a bias. There is also one critical point that is important whenever we are considering the screening program or the natural history of the disease. This point in the natural history before which the treatment is more effective or less difficult to administer, meaning that the potential of curing a person can be at is important, and at this is at one critical point. If you apply a screening test close to that critical point, then the person have a better chance of survival and a better outcome from the treatment, and is more effective. For example, in a woman with breast cancer, one critical point would be that at which the disease spreads from the breast to the axillary lymph nodes. If the disease is detected and treated prior to the spreading, then prognosis is much better than after the spread. Better explained by this whole figure, that the critical point is somewhat theoretical, because we usually cannot identify when the critical point is reached, but the point is to consider is that there can be single critical points and the multiple critical points, and early and screening through screening program we can detect these critical points, and we can easily administer the treatment early, and diagnosis can be done. But since it is all theoretical, we cannot identify exactly when there is a critical point, but considering this concept will help us to develop the rationale for the screening and the early detection of the disease. Whenever we are considering the pattern of disease progression dependent on the natural history of the disease, then 2 points must be kept in mind. That all or most clinical cases of the disease first go through a detectable preclinical phase, and in the absence of an intervention, all or most cases in the preclinical phase progresses to the clinical phase. Both assumptions are reasonably self-evident, meaning that we have to consider the preclinical phase as a phase of most importance while doing a screening test. What are the methodological issues whenever we are considering evaluation of a screening program? The question raises that, can we examine a group of people who have screened or compared their mortality to a group of people who have not been screened? For this, we use different study designs. The observational studies, and case control studies, cohort studies, and other intervention studies like RCTs are preferred for evaluating such screening programs. Different types of biases are introduced due to the use of different types of study designs. And whenever, for example, one of the problem that can logical issue that can be raised while using a cohort design is that the introduction of the different types of biases that would be later on explained. That is one of the bias that can be introduced in terms of observational studies is the selection biases. One of them is the referral bias or the volunteer bias, meaning that whether there was a selection bias in terms who was screened and who was not. The problem of selection bias that most significantly affects our interpretation of the finding is best addressed by carrying out the comparison with randomized experimental studies. So, whenever we are using a non-randomized study design, the problem of selection bias would arise. So, for this purpose, a randomized experiment study design is better, in which there is a comparability between the two groups. Second type of bias is the length biased sampling or prognostic selection. The second type of problem that arises in interpreting the results of the comparison of screened and unscreened groups, mostly in case control studies or other observational studies, study designs when used, is that this does not relate to who comes for screening, but rather to the type of the disease that is detected by screening. So the question is that, does screening selectively identify cases of disease which have the better diagnosis, or could the better outcome be unrelated to the time of diagnostic and treatment interventions? There can be a prognostic selection of the a bias. We are identifying only those cases who have a better prognosis rather than the cases who have varying prognosis. So there can be a prognostic selection bias. So there are facts and data that support that longer and shorter preclinical periods affects the selection of the candidates. And whenever we are using these, we are considering the natural history of the disease, it is important to consider the length of the preclinical and the clinical phases. Like in this case, there is a short natural history of short preclinical phase and clinical phase, whereas there is a long natural history of preclinical phase and clinical phase. So whenever we are considering a group of people, we have a varying number of people who have different lengths of clinical and preclinical phases. So this can introduce a bias, also known as the length time bias, that will be explained in the coming slides. Whenever we are using this type of approach, so experimental randomized design is preferred, in which there is comparability. And when we are using a randomized sample, then comparability in terms of lengths of the detectable preclinical phase can be made. And whenever we are using such a study design, in the screen groups, survival would be calculated for those whom the disease is detected by screening, and for those whom the disease is detected between screening and examination, and this period is called the interval cases. So the benefits we seek in the screening is either in the delay or the prevention of the death. This is one of the outcomes. It can also be in terms of morbidity, or improvement of any other symptom. So this is the in terms of the, as we can say that in figure 1 is the outcome of diagnosis at usual time without screening. In B, there and B, from B to D, it is the outcome can either be the usual time of death, the delayed death, or no death from the disease. These three pictures depict that the the nature of the disease, how progressive, how aggressive the disease depends on the defines the this whole outcome. And with early diagnosis, we can have three types of outcomes: either its usual time of death, delayed death, no death of the disease. So we are all considering the screening program whenever we are evaluating. First of all, we are considering the preclinical phases. We are giving the early diagnosis, but there are multiple factors that affect the outcome of the disease despite the fact that we are using an early diagnosis, and that is the varying periods between preclinical and clinical phases, or the length time, or the lead times we are getting. So the lead time bias, as I've already explained, was a problem of arising with due to this due to comparing survivals in people who have been screened with a survival. Whenever we are considering a survival, then we will get a lead time bias, because we will see in this figure that how this lead time would affect the 5-year survival. But this 5-year survival index can be misleading. Like if we are screening two groups and we're getting a survival, we are evaluating the survival. So for the lead time we'll get due to the early detection might be misleading, because there is an index that is also known as a 5-year survival, and 5-year survival is starts from the time of detection of the disease by the screening test, and till the death. So there in this C picture, if you can see that the biological disease started in 2008, it was detected by screening test is 2013, and if the usual time of diagnosis was done, then it was in 2016. So we diagnosed the case 3 years earlier, but still the patient died in 2018. So this time was between 2016 2018 was 2 years. Before that was the lead time bias. On the whole survival time, if we did not have that done, this would have been from 2013 to 2018. For example, the patient became aware in 2016 and had a diagnostic workup leading to a diagnosis of colon cancer. But after that, the patient only survived for 2 years rather than for 5 years. So this can be an illusion. This doesn't matter that if we detect the disease early can increase the survival time all the time. It applies like that. It depends on the aggressiveness of the tumor, of the disease, how is the prognosis of the disease, what is the condition of the disease, and other factors related to the patient. So this can be a illusion, that is 5-year survival. We can get a lead time, but it does not. It depends that it effectively increases the survival. It was only an illusion that we diagnosed it early, but later on the patient died after 2 years. If we would have done in all other cases, then the similar picture would have been achieved. I think you might get my point. So there is also an overdiagnosis bias, which is due to the overdiagnosis using the diseases that are mostly more sensitive diseases, uh, and the more ambitious inclusion exclusion criteria and case definitions. So the for example, the at the times people who initiate the screening program have almost limitless enthusiasm, and like the cervical cancer, the pap smear can be over used, and this can cause an overdiagnosis bias in people with having false positive readings. There is also misclassification bias, like the people who were selected in the study groups were not selected appropriately, causing the misclassification, and there was not randomization and the variability of the variability between the samples. Like in a cohort, the two cohorts were not selected properly, and this could lead to misclassification bias. And this could be reduced by increasing hiring and employers or using a record that helps to strengthen the workforce and streamline your work. So, when using different study designs, so randomized and non-randomized study designs are preferred. Most commonly used are case control study designs, and cohorts and prevalence studies are also used. But this gives a weaker evidence. Case control studies and cohort studies are commonly used, but the preferred is the randomized study designs. So whenever we are using the non-randomized study designs, so case control studies are defined, but this bias of selection bias and other types of bias can be misclassification biases can be introduced in such a design. So randomized study designs are preferred. For example, this was a screening program that was done for the breast cancer, and it includes the screening, including mammography and the regular care. And the randomized studies, the population is randomized, and half were screened and half were not screened. And such a study is, since it is difficult to mount, but still the evidence that is generated by this randomized study design is better. Cost benefit analysis is also important. Some people respond to cost benefit issues by concentrating only on the cost, asking if the test is inexpensive, why not perform it? Actually, the cost analysis shows that it is not the cost of the test, it is cost of the whole of the follow-up period. So this is also very important while we are evaluating a screening program, including the study designs, the biases, and other factors depending on the survival, the mortality, and morbidity. Interpreting the study results that shows no benefits of screening. In these chapters, mostly it was stressed between the difference between the screened and unscreened groups. However, if we are unable to demonstrate a benefit from the early detection of disease, any of the following interpretations may be possible. Either there is an apparent lack of benefit may be inherent in the natural history of the disease, that is, the disease was not detectable, or there was a short preclinical phase, or the therapeutic intervention currently available may not be more effective when it is provided earlier or when it is provided at the usual time of diagnosis. So this was all about the presentation. Now there were some recent advances in which one of the articles that shows a case control study to evaluate the impact of breast cancer screening program. And a conditional logistic regression was used for evaluation. Results were there, and it shows that incidence with the national incidence data to estimate the absolute rates of overdiagnosis. Overdiagnosis was calculated as cumulative excess of cancer diagnosed in this age group, and the NHS screening program in England confers to the worst modest level of overdiagnosis. So this can be an overdiagnosis bias that is common with a screening program that uses more aggressive techniques. This was another paper that shows the surveillance in the NHS bowel screening program. This was a randomized blinded control and under NHS for the bowel screening program. And this showed that both the agent displayed, both these agents, these and this, were used for the considering of the efficacy, and which was specified to adenoma type and incompatibly known for the activity. Actually, this showed that there was a specific they clearly defined that there was not associated with reduction of the specific outcome measure that was intended for this disease. So this randomized control trial was a better rather than this case control study design. This was also the safety and cost effectiveness of individual screening for diabetic retinopathy. It was an RCT, and cost effectiveness was evaluated within 2 years of time. And the evidence over the 2 years of time was important. And since it was a randomized control trial, the comparability was there, and the generalizability was good. So for the implementation, the long time frame of the disease was addressed, and it is also applicable to other settings where the clinical data is available, such as healthcare delivery organizations and polyclinics. This was the Pakistan studies done in Pakistan evaluating the screening effectiveness of hepatitis B surface antigens. This was a single center cross-sectional study design that was done in the this relevant department of pathology. It was used for the rapid testing kits, and sensitivity was and specificity was compared. Comparatively, it was seen that it was expensive and the quality of methods are more as compared to the rapid devices. But later on, it was also explained that further randomized studies are needed for the confirmation of the results, because since it was a cross-section study design. So, in continuation with the previous Pakistani article, this was another Pakistan article that addressed the that laid the emphasis on the use of the other types of study designs for the study evaluation of the sensitivity and specificity, and making an algorithms for the evaluation of the screening. As you can see in the lifestyle that account for the priorities for increased case detection and sources required testing for additional individuals with presumptive TB needs more and more follow-up studies as follow-up studies comparing different versions of this disease. So this was in continuation of this article. Now it's time for the MCQs. A decision of making a screening program for lung cancer is best made based on which of the following: the widespread availability of technology, advanced imaging equipment, the availability of data from randomized controlled trials, the free services of lifetime smoking celebrities, and the strong political support of the foreign agencies. A decision of making a screening program and a good screening program, and then later on good evaluation. Any idea? It depends on the availability of the data from the randomized control trials showing the benefit of screening tests in reducing the mortality or morbidity. While evaluating a screening program of breast cancer, using the randomized control trial, following types of bias would be reduced by randomization: ascertainment bias, recall, selection, publication bias in handling dropouts.
C.
Yes, it's selection bias. A group of students ABC are studying research where they are given a task to evaluate a screening project of cervical cancer using natural history of disease and clinical stage. Select the stage in which there is a presence of factor that favors the occurrence of the disease. Either it's the stage of susceptibility, the stage of preclinical symptomatic disease, the clinical, or the disability. Any idea?
B.
Yes, it's B, symptomatic, pre-symptomatic stage. A medical student is performing a chart review to assess the survival duration among the clinic's dialysis patients. The poll charts of the patients had seen that months patients that were on dialysis and the survival duration would seem much higher in the student samples of the patients than that of the literature suggests. That is due to the length time bias, ascertainment bias, recall bias, selection bias, or bias in handling dropouts. Whenever we are using a survival duration, and the survival duration varies as
D.
compared to what has been suggested in the. And it's D, the length time bias. Yes, it's the right answer. It's the length time bias. Case control studies and cohort studies are frequently used to evaluate the screening program. But the main limitation is that the study groups may not be comparable because of confounders in lead time bias, randomization, blinding and increased external validity, effect modification, and recall bias.
D.
It's confounders and lead time bias which causes the difference in the comparability of the groups. A group of doctors conducted a study with meta-analysis of body size and development of prostate cancers. The criteria used to define non-aggressive and aggressive prostate cancers varied between cohorts, which may lead to recall bias, misclassification bias, Parkinsonian bias, lead time bias, length time bias. When the selection is compromised and the criteria used is differs the non-aggressive and aggressive prostate and varied cohorts, then it's which type of bias?
C.
It's B, misclassification bias. In a hospital XYZ, the postgraduate students in the oncology ward were directed to evaluate colon cancer screening program. Getting data on recently introduced sensitive diagnostic tests, incidental findings, and widened diagnostic criteria to define the condition. Which kind of bias can be introduced using sensitive diagnostic criteria? It's recall, it's overdiagnosed, it's Parkinsonian, lead time, or length time bias. Any idea?
E.
Yes, it's B, it's overdiagnosed bias. A group of researchers XYZ targets an unscreened population by nearby who will be included in an assortment, and screening tests for cervical cancer will be applied. Which of the following factors most affects the length time bias of a study? while identifying the outcomes of the patient like symptoms of geographic distributions, subjects with long and short preclinical phase, subjects with mild symptoms, subjects with prompt treatment, and demographic characters of the population. Whenever we are considering the length time bias, length time bias. Basically, it's beginning with the long and short preclinical phases is what we are focusing when which is the main factor leading to the length time. In our XYZ, a team of researchers went to evaluate the ongoing screening program on hypothyroidism and its prevalence in a specified region. Which of the following is the best reason to evaluate a program? Either assess if a project has achieved an intended goal, identify only those who have the disease, calculate the budget spending to date, treat the patients with hypothyroidism. A, assess if a project has achieved its intended goal and purpose. And last MCQ, which of the following is true about screening test? All screening tests do good with equal margin harm. A test can only qualify for a screening if there is multiple patient testing positive in the screening. The health service capacity to cope. The choice of diagnosis test is done by the patient. Any idea? See, a test can only qualify as a screening test if there are multiple patient testing positive with the disease, or health services must have sufficient capacity to cope, or any idea? It's C, the health service must be sufficient capacity to cope with the disease, follow up and treatment. So this is the key, and thank you.
Assalamu alaikum, everyone. Thank you very much for a very informative presentation. And I think there are some confusion in a few of the MCQs. So we would discuss in detail during face-to-face meeting today.
Okay, ma'am.
Thank you very much, Dr. Amber, for a very informative presentation. Allah Hafiz, everyone.
Allah Hafiz.
Allah Hafiz.